Vitamin D dependent rickets. Okay, so refractory rickets, it could be two. It's either vitamin D dependent rickets or it's hypophosphatemic rickets. Primarily is only these two. Apart from that, rare causes can be renal tubular acidosis, but we don't want to go into the rare causes right now. VDDR is vitamin D dependent rickets. These are autosomal recessive disorders. In contrast, the familial hypophosphatemic rickets, those are X-linked dominant disorders. X-linked dominant disorders are comparatively a countable number of disorders only are X-linked dominant. Familial hypophosphatemic rickets was one among them. So the VDDR occurs in infants between 3 months and 6 months of age. They don't respond adequately to nutritional rickets. Clearly, these are refractory rickets. Okay, so VDDR is of two types, type 1 and type 2. Type 1 is because of deficiency of 1 alpha hydroxylase in the kidney. Type 2 is due to end organ resistance to vitamin D3. Calcitriol. Okay. So what happens in case of vitamin D dependent rickets type 1? So in VDDR type 1, what happens is the calcium level is low and the phosphate level is normal or it is low, and then the alkaline phosphate is very high, the alkaline phosphatase enzyme. The blood levels of D3 are normal, that is, the D2 is normal, but the D3 is very low, despite okay. So what happens is there's this enzyme which is 1 alpha hydroxylase, which is converting D2 to D3. D3 is the active form. D3 is the form which helps to increase the calcium level in the serum. So what happens here is that the 1 alpha hydroxylase is gone. So the D3 is not going to be there. The calcitriol is not there. Only the calcidiol will be there. So what happens is the calcidiol will be very high. That is 25 hydroxy cholecalciferol will be high, but 1 comma 25 dihydroxy cholecalciferol, that will be low. That is, the active form will be low, the inactive form will be high. So what happens is the calcium level, which is supposed to be high because of vitamin D, will not happen because there's no vitamin D, which is in the active form. So the calcium is less. The phosphate may be normal, may be low. The alkaline phosphatase is elevated. We know why the phosphate is low. It's low basically because of the PTH. So like PTH is gonna kick in if the calcium is less. That's the immediate next step. What happens in case of vitamin D deficiency? And then alkaline phosphatase is high because bone resorption mediated by PTH is going to cause the same thing. The clinical features are almost similar to vitamin D deficiency. The only major points of difference is that there's a positive Trousseau sign and a Schwarzschild sign. Apart from that, there could be hypotonia, growth failure, motor retardation, that is poor head control, delayed standing and walking, convulsions because of hypocalcemia, anemia, respiratory difficulty, and all the examination findings, head to toe findings, will all be as same as the vitamin D deficiency. The only main differences is that there will be motor retardation, like marked motor retardation. That is one point. Second point is there will be respiratory deficiency. Third is there will be Trousseau and Schwarzschild sign which are positive. Okay, motor retardation, respiratory difficulty, Schwarzschild and Trousseau signs. Apart from that, convulsions can also occur because of hypocalcemia. Treatment is giving D3, that is calcitriol. It's also called alpha calcidiol. Calcitriol is given. The dose is 0.25 micrograms per day. So it is treated along with calcium, with or without a phosphate. And then the calcium level will increase and the X-ray findings for bone healing will be increased in approximately 1.5 to 2 months after treatment. Moving on to type 2. In type 2, there is end organ resistance to D3. So D3 level will be normal or is markedly raised also, but then there will be hypocalcemia. Early onset rickets, so like vitamin D is a sunshine vitamin, so the clinical features will be in the topmost part of the body. For example, there'll be hair fall, there is alopecia, and then oligodontia, meaning more than 6 teeth will be lost in the mouth. Milia, which is also kind of like a verkuru, and then epidermal cyst. Hypocalcemia, secondary hyperparathyroidism, elevated D3, absence of response to vitamin D analogs are either. Treatment is calcium. Large amounts of calcium has to be given. IV or oral calcium is